Hi guys, this is Charles. I'm one of the surgeons at Southpaws. Today we're doing a C4-5 ventral slot in a Cocker Spaniel that has a cervical disc rupture. Presented yesterday with really severe neck pain and neurologic deficits to the forelimbs. So we've done a CT myelogram, and you can see that in the upper right-hand corner of the screen, which shows a sagittal section of the spine and the myelogram, and you can see that there's a big disc bulge at C4-5. You wouldn't be able to tell from that CT if it was C4-5, but I can tell you from looking at the whole scan that that's the case. And so we're doing this ventral slot. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so that you'll get a ding on your phone the next time we live stream. So we have the chat going on at the same time, so if you have any questions, you can certainly feel free to ask them. And if I'm in a place in the surgery where it's not too crazy, I can answer them. And we'll see how we go. Now, the key thing when you're doing a ventral slot is to make sure that you stay on midline. When you go off midline, then you really get lost, and that can cause that can cause major problems with finding your anatomy. If you find that you're approaching off midline, then it's really hard to find the transverse processes of C6, which is our main landmark in this area, and it just totally screws you up. So can I get some new Mets and bombs, please? These are quite dull. So I'm just approaching the midline here, going through sternothyroideus and sternohyoideus muscles, just splitting down the middle here. For those of you that are joining a little bit late, we're doing a ventral slot in this dog with a C4-5 cervical disc rupture. You can see the CT myelogram right there and see that big disc bulge. I'll take those guys there. Just replacing my Mets and bone scissors because these are quite dull. Just give these to Ray, please, to get them sharpened. Thank you. Hopefully my head won't get in the way. My big surgeon's head. Just splitting down the middle here, and then the first thing we're going to see is the trachea right in the middle of the way. And there's a question what the best way is to identify midline, and it's basically just making sure that the dog is perfectly on its back, and then making sure that the legs are tied back symmetrically. And those are the two main things that we use. You can also palpate the structures in the neck, like the spinous processes, that kind of thing. Can we get Bipolar plugged in, please, and turned on? And I really like using Bipolar for these. You get a lot less twitching of the musculature. Let me just see what kind of view we've got there. I'm just going to move the camera a little bit. 30, please. Whoops, wrong direction. Sorry if I'm making anybody seasick. I'm planning on zooming in, so I need to make sure that I'm centered. Don't give me too hard a time. This is harder than it looks. All right, that's a pretty good view. Can't really complain about that. Oh, somebody's just asked me to move the camera a little bit. It's a tough crowd. All right, so just get my Gelpies in here, and then I'm going to move the trachea and the esophagus to the side, and the esophagus is on the left-hand side, so that's on this side of the dog. So I'm going to retract everything from the, left side is over here, and I'm going to retract everything from the right to the left. So I'm just digitally palpating in here and starting to get a sense of where midline is, which is right down there. The other thing that we need to look out for is the vagus nerve, vagus sympathetic trunk, which is right in here. And I'll point that out again before I get too far along here. So first thing I'm going to do is palpate the wing of C6 down there. So C6 there. So that's C5-6. So C4-5 should be right about there. All right, so go back and repalpate. Again, I'm looking to make sure that I'm on midline. So that's C6 back there. C5-6, C4-5 is right there under my finger. Let's see how centered that is. It's a little bit farther caudal than I had anticipated, and so I'm going to have to move my light again so you guys will be able to get a view down there. All right, so just palpating again, C6, C6, C5-6, C4-5. All right, so just going to move the whole apparatus cranially so that then I can point backwards. Can you move over a little bit, Katie, please? Can you release that? Sorry, the charger for the camera is caught on that hook. Just push the charger over to the other side. That's it. And then that should be pretty good. All right, so that's the spot right there. I'll extend my incision a little bit more as well, so it's more central. All right, so that's it right there. Now I'm going to use my bipolar to just clean up some of those muscular attachments. Get another Gelpy in here. I've got one here. If you're doing either C6-7 or C5-6, it's really hard to get Gelpies in there because of the really big transverse processes of C6. So we're lucky we're not at that site. Alrighty. It's really important when you use Gelpies for any surgery that you keep repositioning them to make sure that you're getting the biggest advantage that you can out of them. Can we get that zoomed in, please? So let's see, questions. Go ahead. Yeah, so that remote control that's right there, point it at the camera, and then do telephoto. And let me just see. Go ahead. Keep going. Keep going. Keep going. Yep, that's great. Thanks. All right, so questions. What was the presenting neurologic sign? So just painful and a little bit of ataxia in the front legs and CP deficits. Breathing was okay. And dogs can get scoliosis. It's more common in brachycephalic breeds. And last question, I didn't get to see ventral slot during my surgery rotation, but since my dog had a ventral slot a few years ago, I'm very interested. Great. All right, so let me just get rid of a bit of this fascia up here. Got a better view. All right, so I'm just coming in here with my Ruskin rongeurs. I'm going to take a bit of that ventral protuberance there off. All righty. And I'll switch over to an 11 blade. I'm going to use the 11 blade just to cut out the annulus fibrosis, just like that. Just so I don't push it into the spinal canal as I'm drilling. Come in with a little rongeur, try to pull that out. All right, and now I'm ready to start drilling. So what we'll do is we'll get a syringe. We'll fill it with saline and just do about a drop a second on the burr, okay, guys? There you go. And you want to stay again on midline as we burr.
Just so you know, Charles, I've just turned his phone up to 10.
Okay, he's still reactive?
Well, I'm waiting now.
Okay. All right, so we can start getting an idea of where that annulus is, right in the center there. Is my head in the way? Now you should have a pretty good view of that disc right in the center there. And you'll find that as you're burring, the disc space actually moves cranially the deeper you get. Can I get a big flush, please, for me? Terrific, thank you.
I'm still just struggling to keep his CO2 down.
What are you on?
He's on 56 now. It did go down before, but it came back up.
All right, so what rate is he on?
He's on 17.
You can put him up to 20 if you'd like. The other thing you could do is switch to a smaller, although he's a big dog, he shouldn't need a pediatric circle system. We're just having some problem keeping his CO2 down. Okay. Big flush, please. Great, thank you. Okay. I reckon you guys have a better view than I do. I don't know if you can appreciate how the space is going. So this is rostral up here, and that's caudal back there, and you can see the space heading rostral the deeper we go. Big flush, please. Thank you. The nice thing about this Zoomx drill is that I can lengthen the burr as you go deeper, so I can actually move that out. If you look at the end of the burr, you can see that it has little teeth, and so I don't have to push it all the way in. I can pull it out a little bit, and that gives me a little bit more length before it hits the the edge of the shaft. This is a striker system. Okay, thank you. What I'm looking for is to get back into cortical bone. So if you look down there right now, you can see that there's a white stripe in the middle of cancellous bone. And I want to be on cortical bone, cranial and or rostrally and caudally. That'll tell me that I'm getting pretty close. The reason why I'm dripping saline is, number one, to cool the burr, and also to keep debris from getting caught up in the flutes of the burr. So it's starting to get white around there, so it means we're getting down to cortical bone a little bit better. Can you just drip some saline on the rest of the tissues there? Just to keep them from drying out under the hot lights. Thank you. Now we're getting there. All right, I think we'll hold off on saline now for a little bit. So I'm trying to avoid the vertebral sinus, which I cannot see yet. All right, so I'm going to get a pick out now and see if I can start picking some disc material out. So that's dorsal longitudinal ligament that I'm picking through right there. So there's some great disc material coming out there. I assume you guys can see that. So that's all disc material that's coming out there. So that's a great result right there already. So this dog will already be much, much more comfortable. But we'll keep working on it and make sure we get everything out. Head's in the way? So basically what I need to do is keep picking until I can clearly see spinal cord, or it's bleeding and I can't get the bleeding to stop, and so then I just give up. Generally, I get to the point that I can see spinal cord pretty clearly, but occasionally we have to abort the procedure because of the bleeding from the sinus. Prognosis for this guy is excellent. So these guys, about 98% return to good function. Yeah. I beg your pardon?
Is it possible to heal complete the procedure? Maybe just complete the procedure if the patient is incredibly inflamed?
It's still like the inflammation in the area doesn't affect your ability to get all that disc material out. So I can see spinal cord now right here. It's just a little bit peeking through. Head. And we do not do anything to fuse this as long as there's not any evidence of severe instability. So if it's just a pure type 1 disc, we don't stabilize them. We are on a ventilator. Every patient that comes into surgery pretty much goes on a ventilator. It's just easier to keep them deep under anesthesia. We can regulate their CO2 a little bit better. So, all right, so I'm just going to stick my head in the way for a minute and just make sure that I can see everything that I need to. All right, so I'm really pleased with all the disc that I've been able to get out of there. So that is spinal cord, that white right there. I don't know if you guys can see that. but that's spinal cord there. And so if I can see spinal cord, that tells me that I've gotten all the disc material out. So really good view of spinal cord right there. All right, so let's try to zoom in a little bit more before I'm ready to quit. Point it at the camera. Yeah, keep going, keep going. Yeah, okay, so let's just do some flush. Just grab the syringe and flush in here a little bit. Yeah, that's great. So at the bottom is the spinal cord. So if you can see white, that's spinal cord sitting right there. Can you guys see that? Can you see that, Katie? Yeah. All right, so that means that if I can see spinal cord, that means that there can't be any more disc in the way. So that's it. Now all I'm going to do is check for stability. So I'm just going to push on both sides and see if I've got a lot of mobility. I don't. So we're pretty much done. Now the only thing left to do now is to inject some mepivacaine. So I'll get a dose of mepivacaine there, and then while I'm waiting for that, I'll just have a look at the questions. Couple of requests to move my head, fair enough. That's pretty much it. All right, so we're just, again, waiting for our mepivacaine, and then I can start my closure. Thank you. You guys do have a better view than I do. Any questions about that or anything else? We're just waiting for the mepivacaine for a minute. Where's the needle? Can I just grab that needle, please? So the rongeur that I use, I have about a 5 mil one. And that's probably a little bit too big for this dog. We do have smaller ones that are 3 or 4 mil. And then the Lempert rongeurs that we use are about 2 mil. So I'm just splashing the mepivacaine everywhere. Can I get some 3.0 PDS, please? And then when I'm coming out, I just need to be careful not to stick my Gelpie in the carotid artery or the esophagus. I don't know if you guys can see that right there. That's the carotid artery sitting right there. And then right next to it, you can see it pulsing there. So that's carotid artery. And then right next to it is the vagus nerve. So the vagus nerve is sitting right there next to the carotid. So that's the vagosympathetic trunk in there. And then we've got the carotid artery there. And then on the trachea, we might be able to see the recurrent laryngeal nerve. I'll try to have a look for that when I finish up this part of the closure. So I actually love ventral slots. I really like hemilaminectomies, but ventral slots are, I reckon, look, they're certainly no harder. Occasionally you get some bleeding, which can be annoying, but besides that, they go really well. There's very, very little chance of doing iatrogenic damage to the spinal cord, in contrast to a hemilaminectomy where it is certainly possible that you could damage the spinal cord. You'd have to be a really rough to damage the spinal cord in a ventral slot because it's so well protected, and you're only looking at a very small segment of it. You're not, really digging underneath it or anything. So. Can you let them know out there that I'm ready for my next one?
Yeah.
I think that's all the surgery that I have today, but I've got some other workups that I have to do. One is a really interesting case of a year-old golden retriever that loves to shake his dog toys, and when he shakes his dog toy, he has nystagmus that lasts a few seconds afterward. And so we're going to do a CT scan and see if there's any fluid in the bulla. We'll also look at the brainstem to make sure there's not a lesion there. If everything is normal, I may do a CSF tap to see if he's got some early steroid responsive meningitis or something like that. No, you can ask me now. That's right.
Painfully, he's already on a Fed CRI. Would you like to switch to methadone or keep on the CRI?
No, methadone is great. All right, so I've got my trachea sitting here, and the esophagus is over there, and I can barely see the recurrent laryngeal nerve sitting right in there. I'm not sure if you guys can see that. That white structure right there is recurrent laryngeal nerve. I'll point to it. Right in there. That's recurrent laryngeal nerve right there. Sorry, Jess, go ahead.
Sorry, Fed patch after that?
Fem patch is great, yeah. Can you zoom out, please?
Dog's previously been on Medicaid. Do you want some more?
Yeah, that's great, thanks. Terrific, thank you very much.
Are you okay with the subcut injection?
Yes, please. He was never hypotensive, right?
No.
Okay.
Is it just a loading dose or maintenance?
Maintenance dose because he's been on it, and then just oral when he's awake. Can we get that cut, please? Grab a scissor.
Capsule overnight?
No capsule overnight.
Sedation?
If necessary, yep.
Anything?
Yeah, ACE or DOME. So we're just going through our post-op checklist to make sure we're all on the same page about what the patient needs going forward.
Just asking if physio is extra charting.
Yep.
Rechecks?
At 2 weeks only, if it's doing well. If they have any concerns, then come back at 1 week.
Someone's asked how much bone would you remove before you decide you need to use it?
So if you stay less than half the width of the vertebral body at the slot, you don't significantly weaken the joint enough to have to fuse it. If I found myself taking greater than 50% of the width or started feeling like I was getting some instability between the two vertebral bodies, I would consider fusing it. And the way that I would fuse it would be just pins and methacrylate.
Any concerns about respiratory paralysis from repeated pain on the spinal cord?
That's a good question. I have never seen that, and I've given a lot of doses of mepivacaine. I have seen some dogs with that are hard to get off the ventilator, but just from the original injury, not from the mepivacaine. How much does he weigh?
18.
I reckon probably a 50 with a little bit cut or folded. Thank you.
Have you felt the bed touch going on the foot?
Yes, ma'am.
It's just I'll ask Charles. Yeah, no. Would you like a recap?
No, thanks. It was fully ambulatory beforehand, right?
I don't really know much about his.
Yeah, no, that's fine. He doesn't need a urinary catheter. Can I get some 3-O-monosin, please? Thank you. Haven't quite convinced the other guys to live stream. James, I think, is close. And Ricky, I think I've got a bit more work to do. Kath live streams with me because she doesn't have any choice when I'm doing the surgery. Can you just run that for me, please? Sorry, Katie.
Oh, sorry.
All right. I know there's something really good on TV, but
I was seeing if there's any questions.
Someone was praising your surgery.
thank you. I should, yeah. I've had a lot of practice, but not lately because the residents do most of the closure. Very exciting that Kath and Steph are finishing their residencies in January, and they'll be staying on as staff surgeons, hopefully taking their specialty boards next year. And Alex is taking her specialty boards as well. What's that? Isn't it? So many surgeons. To find something for everybody to do. I am finished with bipolar, thank you. On the cord with respiratory paralysis? Yep. Yes, we always ask, and they know that it's anonymized, which means that nobody could ever know who the pet was. And we've never had, actually we've had one person say they preferred not to. but that's really rare, especially since it's for educational purposes. People are generally pretty happy. I have finished a surgery a couple of times, and I call the owner and say, I'm just want to let you know that we're done with surgery. Everything went fine. And they said, I know, I was watching on Livestream, which is always a little bit scary because you wonder if you said anything inappropriate. As long as it was just a few dad jokes, that's all right.
Well, that's a must, isn't it?
Yeah. All right, and when I'm finished with this, I'll come around and have a look at the computer to make sure that we haven't missed any questions. And we're right up against the skin, perfect. All right, so that's it for that surgery. Let me just come over and make sure that we've answered everything. That's great. Mr. Widget says hi. He's a portosystemic shunt. I'm glad that he's a fan. So we currently have three residents at our practice, and 2 of them are finishing in January, and then we will have Jeff move up to a residency, and we're hiring another surgical intern. And then as far as qualities are concerned, in a resident, we want somebody who's clever, and most importantly, that they get along with people. And we really like a good sense of humor, good attitude, hardworking, that kind of thing. So we don't even look really at grades. I don't think we've ever looked at transcripts for any of our residents. It's just really, really about how we can work with them and how they get along with other people. Letters of reference are really, really important. And just looking to make sure. Nope, all good. All right, guys. So anyway, thank you very much for watching. I don't have any more surgeries today that I know of. If I do, I'll be sure to stream them if I can. And I may try to live stream just a question and answer session with maybe some photos. And Chris Wood says, and how they bake baklava, which is, I'm not sure if Chris made baklava here. I know that Jason does, yeah. So Jason is definitely, trying to front up for a residency at some point by baking baklava for us. And Chris, I assume that you're already working in Canada. I hope things are going well. And obviously you're not working that hard if you're able to watch live streams. Anyway, tell Julius I said hi. And thanks to everybody else who's been watching.